Hi, my name is Wael Al-Delaimy. I'm a professor of public health and family medicine at the University of California, San Diego. So our study looked at the Women's Health Initiative study, which is a long-term cohort study of more than 20 years. We want to ask the question, do people with pre-existing mental illnesses or symptoms of mental illnesses have a higher risk of developing COVID, including long COVID or COVID complications? And we found that those with more severe mental illnesses, and especially those who have both depression and anxiety, are at higher risk, significantly higher risk, about 78% higher risk of developing long COVID. And that is an important finding for future pandemics and for those who are still kind of suffering from long COVID, that we need to understand potential risk factors for them. What we did know during COVID, that those who developed COVID and even those who did not develop COVID, because of the pandemic and the isolation and the quarantine, that many have developed mental illnesses, depression, anxiety, etc. We also know that those who got the COVID and the complications were long-term, and that caused also symptoms of depression and anxiety. The question came, well, what about those who had pre-existing mental illnesses? How does that play into this kind of association? So we're looking at pre-COVID, and the Women's Health Initiative offered us this amazing data set where the information about anxiety and depression was collected over multiple time points. So that gives us a really amazing window in the past about those who had persistent reporting of mental illnesses or symptoms of mental illnesses. So we looked at those folks and compared them to those who did not. And those were more, elderly women, because the Women's Health Initiative was specifically for women, and they're older, like in the average, their ages were around 80. So they're very different from the general population, and that makes them also at higher risk, which made a good sample to look at this. We found one of the things that were interesting is that we did have information about mitigation factors that are factors for protection. Like, do you wear a mask? Do you avoid shaking hands? You know, all of these things that cause the transmission of disease or the COVID infection, which were, highly disseminated as ways to prevent. And we found that those who had these mental illness symptoms were less likely to be using any of these mitigation of masking or prevention task or hand washing. All of these were somehow surprising that they actually were not practicing this, and therefore we expected that they would have a higher risk of getting COVID. But to our surprise, we found that it was associated only with long COVID, that those people only had the complications of COVID and increased that risk. And there are still questions not understood. Why is it that they develop long COVID? Is it biological? Is it something else going on? So that was a finding that was not expected. And I think we are scratching the surface of what's going on with the dynamics of long COVID or the complications of COVID versus just getting the infection positive. I think the most important outcome for those who are in clinical practice is to really pay attention to those category of group of population, mostly the elderly, who are likely to be isolated, suffer from loneliness, and if they also have past history of depression and anxiety, that they have to be at a high level of priority of being contacted when there are pandemics, which we expect we will have future pandemics because of climate change, because of all of what's going on in terms of at the global level, that they have to reach out to them in terms of mitigating the potential of complications. And because they are isolated, that kind of increase the severity of their illnesses. And if they develop an infection on top of that, the long-term consequences are really bad. So that's why it is their responsibility, as well as the responsibility of primary care providers, not just mental health care providers, that they have to look out for those high-risk population based on this study. The interest would be to look at different populations. This is a kind of very high-risk elderly women who are probably living on their own most of the case, maybe suffering from loneliness, maybe suffering from loss of loved ones during the pandemic or as a result of the pandemic. It would be very interesting to look at comparable associations among different age groups, more of the younger age group, middle age, and also maybe look into some of the biological mechanisms that this association could exist. What is it that triggers this long COVID complication among this population? And we adjusted for potential confounders of other chronic diseases, living on their own age and all of that. And all of these were still significant among those with severe, when I say severe, both anxiety and depression, that they independently were at high risk of long COVID. So there's a lot to be learned from this, and looking to the prevention, because we don't want to wait until another pandemic comes and then we see these consequences, but to try and prevent that. I think the study was rather complicated to do because this is a rather complex data set and many factors, but we carefully looked at this over time, and this is the longest duration of reporting on mental illness in relation to COVID. And that is something different from somebody who just asked in the past year or in the past 2 weeks or so on if they had mental illnesses. That could be understandable. But the main concept here is that those who have a long-term chronic problem are the ones who are at high risk. And that is something that we were able to tease out because of the large sample size, but also the long duration and the kind of type of data that was measured multiple times.